So, good evening, all. Uh, it's indeed a matter of proud privilege for me to be introducing this debut session of season 1, episode 1 of Quiz Junction. This is indeed a very ambitious and a very thoughtfully designed project of the Indian Fertility Society. Big thank you to Neena ma'am and to Deya Shweta for encouraging the young budding gynecologists to come onto the national platform and promote pure academics. So we plan to do it in association with a state chapter every month, and we would be having a national stalwart who will be talking to us on a topic pertinent to all of us, followed by a quiz. So I would request Neena ma'am to say a few words and then we get going.
Yeah. Good evening, and to all the delegates, friends, colleagues, members of Indian Fertility Society. I think indeed it's a pleasure to be here on this Friday evening to join you all on this quiz junction, which has been beautifully designed, crafted by none other than Manjusha, who's the brainchild behind this. And I know this is not the first; she's already done it over the last year, and she's taking this. Initiative further in this year. I wouldn't really speak much because I know there's an exciting talk. There's Dr. Sunil Jindal there. And of course, Parul Garg is there from the IFS, who is all there to take you through a wonderful quiz. I know a lot of my residents are very excited. Some of them have joined from my department as well. I wish you all the best. Happy learning and happy quizzing. All the best. Thank you very much.
Thank you so much, ma'am. You have always been an inspiration for all of us. May I now request Dr. Sunil Jindal, whom I have known for not less than 35 years, as a wonderful surgeon, a wonderful orator, and a great andrologist, and a good friend, to please proceed with his talk. And Dr. Jindal would be enlightening us with the male infertility as relevant to a gynecologist. Over to you, sir.
So first of all, thank you very much, Manjusha, for having me for the, I would say, inaugural session of this amazing thing which you're creating. And it ultimately is great to be able to create something which is of use and could be used by everybody. So male infertility is what I'm going to talk about. Primarily, if we look at it in a very, very simple fashion, this poor man is not taken care of in most of the clinics when the child, I would say, contribution of his is about 50%. तो 50% population मेल्स की है इनफर्टाइल में जिनके बच्चे नहीं हो रहे होते एंड दे नीड टू बी टेकन केयर ऑफ फॉर थ्री मेजर रीजंस. Number one, if they are taken care of properly, honestly speaking, most of the people, the results of fertility will be better. The question is not only doing an ICSI, as it has changed everything. Even a man with low sperm count, you would probably say that let's take up the patient for ICSI. And so it has replaced an area where instead of treating the male, what is happening is that the burden of going into an ICSI goes on to a woman in the terms of stimulation, retrieval, and finally ICSI, and the man just has to give a sample. So improving the male sample not only improves the fertility results, it also brings it to a different level, which means a person who probably would have had an IVF could even have an IUI. And at times when the sperm quality is better, the results of ICSI, IVF, or whatever can be much better. Today, especially, I was having a conversation with Dr. Manjusha, and we've known each other for a very long time. And she was saying something very interesting, that if a topic could be such that a lot of things which could be covered, जिसमें बहुत सारी चीज़ें जो नहीं मालूम है एक आम गायनेकोलॉजिस्ट वो खुल सकें. So therefore, I tried to divide the whole program, the topic, into 5 different areas. So I'll begin. I'll just start sharing my slides at the moment. So to start with the program, of course, I would really like to acknowledge Dr. Neena now, who is the president of IFS. And she's been working very, very hard for a very long time in academics. She is the chief of gynecology in All India Institute. And so many people whom I can see here, whom have been known for so long, who have taken part in this. And I'd like to address for everybody at the moment new vistas in male factor infertility. So, if I've spoken about it earlier, that 40 to 50% of infertility cases are because of the man, and it is underdiagnosed, not evaluated. But most importantly, male factor is also modifiable. Now, this is a very important word because modification of the male factor leads to better results and at times even natural pregnancy. I'll give you an example. There's so many patients of mine who come with uh, borderline male factor. It could be poor morphology, poor motility. Now, once they have undergone, and the wife is young, once they have undergone a varicocele surgery, especially those which need a varicocele surgery, the sperm number, their motility, and DNA improves for them to actually have a natural pregnancy. Yes, you may have to put in the wife into a COH or a lateral cycle, but something which would have taken an IUI or at times an IVF would probably be turned into a natural pregnancy. So this modifiable factor is very important. Now let's look at the global incidence. Now this slide is very, very important. Of course, this slide has been drafted by my close friend, Dr. Ashok. And if you look at the data, it's an older data. I mean, it is 2014 population. So you have about 186 to 200 million infertile couples. Now, I probably would think that those people who practice fertility, for them to see this astounding number is great because you have so many people who could need to be taken care of. Now, 50%, if it is caused by women, 20% is caused by both, and 30% by the man, then about 100 million men are those because of whom infertility is there. Now, if you can divide it into two areas. One is known causes, and the other is those in whom it's idiopathic, you do not know. So, in the known causes, which is about 46.5 or 50 million, 30% is because of oxidative stress, and about 50 million of those who are idiopathic, about 80% is because of oxidative stress. So that's a very big number, and it's a very big number which we need to understand. Now, what is the learning objective today, apart from the lovely questions which I'll be answering? I'll just go into 5 areas I'm going to talk to you about. I'm going to talk to you about that WHO has updated the reference limits of semen analysis, and we've got to understand what is different, how to adopt and interpret the new standards. Now, it's a very, very thick manual. So I'll give you the basic points of that thick manual. Second is, there's some new diagnostic tests which have gone beyond semen analysis, which all of us should know about. Third is, antioxidant supplementation is something which is being used. I'd like to bring the rationale of that. And let's learn what is available for an azoospermic man, because about 1% of men are azoospermic. That's a very big number. And the fifth thing, of course, that spermatogonial stem cells represent a novel cell source of reproductive and regenerative medicine, which we will be talking about. Now, semen analysis, we all consider a very simple test, but honestly speaking, it's phenomenally complex. Now, let's look at this slide. So what happens is, we know, number one, sperms are made in the testes, in the seminiferous tubules. So what happens is, you have spermatogenesis. Now, this spermatogenesis is most important primarily because problems can happen in spermatogenesis itself, which could lead to oligospermia, azoospermia, asthenospermia, or there could be DNA fragmentation in the spermatogenesis process itself. Now, these sperms, when they go into the epididymis, that is level 2, there is permeation. They go further into the epididymis and there is maturation of these sperms and storage of these sperms. Then there is ejaculation. Now, when ejaculation takes place, which is in the fourth area, these sperms need a forward motility. There is ejaculation. We all know sperms get capacitated so that the acrosome can fuse with the zona. There is hyperactivation and there is chemotaxis, where this chemotaxis takes place towards the egg with acrosome reaction, and finally fertilization. So, from the time a sperm is manufactured till the time this poor sperm enters the egg, there are a lot of things which happen with the sperm. And anything goes wrong with this sperm, it's unable to do a fertilization. Now, it's a complex process. Fine. But along with that, there are many processes which are part of it. And therefore, it is important for us to know very simply. I'm going to try to, I would say, simplify a complex process so that everybody could really gather the points which they need to know. Now, first of all, let me talk about the sperm morphology. Now, that's a very confusing issue because sperm morphology, uh, a sperm has a head, has a midpiece, has a tail. Now, when we do sperm morphology, we've got to stain the sperms, see the morphology of every sperm, and only sperms which correlate with a proper head, midpiece, and tail are normal. That is why it's 4% by Kruger's criteria. Now, you may say, I get so many reports in which it is 50% normal, 60% normal. This is because it has not been properly done as per Kruger's criteria. Because if you take a good sample, then the percentile is going to come to only 4% normal. This is very important for us to understand. So, whenever you get a semen report, if you see 40% normal, 50% normal, then you would really understand that probably the morphology has not been seen by Kruger's criteria, and you can really understand the importance of that particular report, and probably semen analysis would need to be repeated. Now, let's focus on the 5th percentile. So, laboratories seeking to adopt a new standard should understand that the new WHO does not say it's a normal report. It just shows that out of 100 people who got their woman pregnant within a year, the 5th percentile is this. So anything below it is not abnormal. Anything above it is not abnormal. It is only the 5th percentile. So when we speak to a patient and we say that तुम्हारा sperm count 20 million है count और तुम्हारा count normal है, that by WHO 2021 is incorrect. It is above the 5th percentile. Another thing which has been adopted by the 5th percentile is that there is a shift from quantity to quality and function, which means sperm DNA fragmentation and oxidative stress have been considered in the WHO 2021. And CASA has been placed as a piece of equipment which can be used, and interpretation can be done by CASA. Now, let's come to simple terminologies. So, I could speak about 3 terminologies: oligo, astheno, teratospermia. Oligo means low number, astheno means low motility, and terato means low morphology. Azoospermia is 0 sperms, and aspermia when there is no seminal content in the ejaculation. Now, how would you assess a man? So, the first thing which you would do is take a clinical history. Since there is a lot to speak about, I would probably give you what history needs to be taken in the end in the form of a PDF. Then you would like to physically examine. Now, whenever you physically examine a man, you've got to examine the testis size, the consistency, the volume, the placement. You've got to examine the epididymis, the head, body, and tail, and you've got to examine the vas deferens. Next, you need semen analysis, at least 2 samples, and the gap between them should be 1 month apart. You've got to examine the woman and you've got to evaluate the woman to see whether she's normal or not, especially if the semen analysis, you've got to do it otherwise as well. But if the semen analysis is normal, then it becomes of primary importance as well, though both need to be examined together. Now, if there is a problem and the semen analysis is abnormal, then you need to consult a specialist. Now, on the day 1 of consultation, if there is a gap, please ask for a semen analysis. Now, if it is abnormal now, you would, in the history or otherwise, exclude any gonadotrophic agent. You would do an endocrine evaluation. You would do some additional testings. Now, what all evaluations in endocrine would you like to get done? You would like to do, in case the semen count is very low, less than 3 to 5 million, you would like to get done an FSH, LH, testosterone. In case there is a sexual problem which is present, you would also do a prolactin. In case you feel the man is obese, you would like to do an E2. These 5 tests would make us and bring us to a place which will give us a fair idea with the semen analysis, or which is the area which has to be looked into. You could do some additional testings like genetic evaluations. Now, genetic evaluations could be, in case you can't feel the vas, a cystic fibrosis testing. You could get done in azoospermics or severe oligospermics, a Y chromosome microdeletion, and a karyotyping. Now, in case the semen volume is low, you need a transrectal ultrasound to judge if there is any problem in the seminal vesicles or the ejaculatory duct areas. At times, you need an MRI as well. Now, scrotal and urinary tract sonography. Please listen to me what I say. The testis lies outside the body. You can examine it. You can feel it. So the testicular ultrasound and the epididymal ultrasound doesn't have much value. What has really a value is to evaluate or to quantify. You don't first of all, you don't diagnose a varicocele on ultrasound. You diagnose a varicocele on examination. But you could document it by an ultrasound. You'd like to do an ultrasound where you're not being able to judge the testes properly. You'd like to do an ultrasound in undescended testes, or you'd like to do it where you find some hardness or cysts present. So, testicular biopsy, testicular biopsy earlier was done very, very often. Now you don't do it till the time you have a freezing facility in cases of azoospermia. Now, also comes is FNAC. Should I get it done? Now, FNAC is a very wrongly used testing, because when in an azoospermia, you put in a needle and it comes as, I would say, somebody would write Sertoli only, somebody would write early maturation arrest. But you know, the testes in azoospermics, especially non-obstructive azoospermia, doesn't have spermatogenesis all over. It has small pockets of spermatogenesis. So therefore, when you open up a testis in micro-TSA, you've got to look for those pockets to take out those particular um, pieces of seminiferous tubules to find out sperms. So FNAC gives a very misleading area to the patients. Now, vasography used to be done earlier, is not done now. Now, beyond numbers, what do we need to test? So, beyond numbers, we could test DNA fragmentation, oxidative stress testing, and what is emerging today is epigenetics and transcriptomic profiling. Now, I'll talk about sperm DNA fragmentation, which has been a game changer. So, this paper of which I am a part of is one of the most cited paper on sperm DNA fragmentation, which has been a new guideline for clinicians. Now, if you see it, you would realize that high DFI and poor ICSI outcomes, they increase miscarriages. And sperm DNA damage can be present even in a normal morphologically looking sperm. So what happens is you have normal looking sperms, you think everything is fine, IUI results are not taking place, IVF embryos are not forming, you have recurrent miscarriages, the patient has a varicocele, and you wonder, सब कुछ तो अच्छा है, हो क्या रहा, क्यों नहीं रहा? Then when you do a DNA fragmentation and you find a high DNA fragmentation, you understand that the cause why all this is happening is because of the DNA fragmentation. Another thing is, in case there's a very, very high DNA fragmentation and the patient has low sperm counts, at times a testicular sperm is a good option because the DFI in the sperm in the testes is supposed to be less and it can be used by ICSI. Now, I'm going to talk about male oxidative stress infertility. If you remember, when I started, there was a slide initially where I showed you how in known causes there's about 30 to 40% oxidative stress, and in idiopathic there is about an 80% oxidative stress. Now, this has been actually classified as something as MOSI, male oxidative stress infertility. And it happens because if you look at a sperm has packed DNA, very little cytoplasm. So what happens is that any kind of pollution, stress, gonadotoxins, toxins, infection, it will lead to stress on this DNA and it will lead to DNA fragmentation. Now I'm going to talk about the role of advanced antioxidants. Now, before I proceed, of course, there'll be so many questions in which I'll answer other questions, practical things which um, I would like to speak to you about. But what is the role of advanced antioxidants? I'm going to speak about 4 antioxidants and 2 after that. See, coenzyme Q10. Coenzyme Q10 acts as the energy provider to the mitochondrial function and energy production. A sperm needs a lot of energy, and that mainly for the motility comes from the mid piece. And this mid piece has ATP, and this production requires coenzyme Q10. Next, we come to omega-3 fatty acid. Now, there's a membrane which surrounds the sperm head and in fact the whole sperm. For this, what you actually need is omega-3 fatty acids, and this also reduces the inflammation. Third thing is L-carnitine. L-carnitine is very important for motility and maturation. Now just consider that if the energy which the mitochondria needs, it needs a transportation. So the transportation of this is done by L-carnitine. And L-carnitine has a very high level in the testes and the epididymis. Next, we have lycopene. That's a very powerful antioxidant which reduces oxidative stress and damage. But apart from this, we also have 2 other antioxidants, which are vitamins, which is vitamin E and vitamin C. Vitamin E is fat soluble, vitamin C is water soluble. These are 2 very cheap antioxidants, very inexpensive antioxidants, which need to be used. Now, I'll come to the assessment. I'm trying to bring in a lot to all of you because in half an hour, I'm trying to pack everything as a chocolate for you to understand the basic concept which you could utilize in your clinical practice. So for azoospermia, you need at least 2 semen analysis. You do 2 things. You do the physical examination and you do endocrine testing. And based on that, you divide them into 4 areas. It could be obstructive azoospermia. It could be non-obstructive azoospermia, which you call as primary testicular failure. You could have borderline or undefined. You could have hypogonadotrophic hypogonadism. Now, obstructive is where the vas is absent. And in these conditions, you would like to get done a few tests, which is genetic testings. If the vas is not well, CFTR mutation, cystic fibrosis testing, an ultrasound scan, a transrectal and abdominal, in case you feel there is some problem with the seminal vesicles, especially if the volume is less. Non-obstructive azoospermia, where you do genetic testings, you want to see the karyotyping, Y chromosome microdeletion. And a lot of people consider testicular biopsy, but in case you do a biopsy, please do not touch the epididymis, because if you touch the epididymis, and in case it spoils the integrity of the pathway, one, and always do it where you could freeze the sperm if available. Now, in any patient of non-obstructive of obstructive azoospermia, you would have probably normal spermatogenesis. But in non-obstructive azoospermia, you would kind of have either a hypospermatogenesis, a late or an early maturation arrest, or Sertoli cell only. Now, I would come to the indefined areas. Now, these are those areas where it is very difficult for you to go into the fact that it is obstructive or non-obstructive. So, a lot of patients with a normal FSH also do not have an obstruction. This is the interesting thing. With normal LH, they may not even be having an obstruction. Anyway, you could have people with a low ejaculatory volume. So you need to see whether the ejaculatory duct is blocked or seminal vesicle is blocked. And in hypogonadotrophic hypogonadism, you would like to give these patients hormones, SCG and HMG, to get sperms back. Now, in case there is no ejaculation, you'd like to see if there's any retrograde ejaculation, or you'd like to do TRUS and do fructose testing. So I have told you they could be normal, abnormal, or they could be the duct, ejaculatory duct obstruction. But this also needs to be defined and understood in any male. So I have given you a whole complete idea of the way it is. And EDO is ejaculatory duct obstruction, which needs to be judged in these patients of aspermia and severe oligospermia. Now, microTSA is not just for azoospermia. The indication of this has become also cryptozoospermia, very few sperms. If you could find on centrifugation very few sperms, at times these sperms are of very, very poor quality and high DNA fragmentation. So what you actually need is sperms from the testes. In case you have people with very high DFI, you would need to do a sperm retrieval. And number 3, those people who have had failed ICSI earlier, a testicular sperm may be used. So microTSA is something, microTSA has its role apart from just in azoospermia. Now I'll show you over here what's open needle assisted tubule biopsy. So what happens is that before, at times in a patient who you'd like to take up for a microTSA, you would like to divide the testes 8 areas above the equator and 8 areas below. You would take a very thick butterfly, put a 20 ml syringe, give pressure, give suction, And when you take out, normally a tubule will come out. Now, the moment with the microforceps you start pulling out this seminiferous tubule, you get a reasonable amount of tissue. And this reasonable amount of tissue can be used to find sperms. And if you find sperms in one area out of all the areas you're taking, it's great. And in case it is less, then you probably would open up the testes in that area only to take out tubules from that area. So this is a very useful procedure, especially if you don't do micro-TC, or as I won't say a replacement of micro-TC, but as an area which can be, I would say, before you do a micro-TC or as complementary to it. So you do this procedure. Now, how do you do a PISA? So in a PISA, you take a butterfly, you'll apply a 5 ml syringe, you'll go into that area, have some media in the tube, give pressure, and you will pull out after clamping. You got to clamp it, just remember this. With the pressure, you'd go to clamp it. And whatever fluid comes out, you take it out and send it to the embryologist and the laboratory, andrology laboratory. Now, for micro-TC, what you will be doing is, no problem. What you will be doing is, after opening up a testes under a microscope, you would like to find some areas which would be having dilated tubules. So you open it in different stages. This is stage 1, where you have just opened it up and you wanting to take out if there are any tubules which are thicker, different from this area. Now, in case you don't find anything, you're going to bivalve the testes. And once you have bivalved and opened the testes, you're going to take it out from deeper areas. Like in this patient, if you see, I'm showing you a microscopic picture. So you see this tubule is a thicker tubule. So I've taken out this tubule and given it for testing. To the lab. Just see over here. They're all thin tubules. All thin tubules. But this area you find thicker tubules. So these are the tubules which will be taken out and sent to the laboratory. So you're going to send these small, I would say, centrifuge tubes with tissue, in which we're going to try to find out if sperms are present. And if they're present, we're going to use them for ICSI. Now, just a minute. So just see this video. If you see this video, all this is thin tubules, but can you make out a difference? I'm just trying to show you. With practice, you pick them up, but I'm just trying to show you. These are the tubules which I'm going to take out. Now, it's been a very long time for me to have done see this area, see this area. So I've been doing this for ages now. And initially, it used to really take me a lot of time, a very long time at times in non-obstructive azoospermias, Klinefelter syndromes. But अगर मैं आपसे सच कहूँ, you need embryologist who could work with you for hours together. Just see this. Just see this. And they could just be saying to you, when you would be tired, that I think let me call it a day, एक sample और भेज दीजिए sir. Bas. If you get embryologists like that who can work with you, it is an amazingly satisfying job to do. So just see this. So just see this. Can you see this area? It is thicker tubules. Now I'll just show you how it appears to be in a good testicular sample. So these are all RBCs. So at times people say that they want to remove RBCs. We don't remove RBCs in this quantity because they become a background to see the motility of a sperm. If you see over here, you can see the motility of this sperm. So that's extremely interesting to see these sperms and to be able to pick up these sperms. Now I'll just show you in a sample. If you see in this sample and you would like to see, just go into the sample. Just looking for a sperm to be picked up. And if you see over here, there is one sperm which is present. I mean, I'm just giving you the clip of after the sperm has been found, but at times it takes time. And just go ahead and doing ICSI for this patient with this sperm to be able to give them their own baby. So it's very gratifying to do the azoospermic work, and it's a great job. Really, it's really amazing and very satisfying. Now you come to the AI in semen analysis. Nowadays, a lot of chambers are coming, a lot of machines are coming. They have become cheaper, especially AI in semen analysis and AI in embryology. So sperm quality, embryo grading, and sperm selection for ICSI. AI is being used to grade the sperms and also to find the embryos which would probably be the best to give you babies. Now, when you come to sperm selection, especially of DNA fragmentation, there are few sperms. There are about a few things which are being used now. One is microfluidics. So it filters the best sperm via flow. Then you have IMSI. It uses 6000x magnification. Then you have PIXI. It selects a mature sperm with hyaluronic acid hyaluronic binding. And genetic screening in a man, of course, is very important. So you need a Y chromosome microdeletion to be done. You need CFTR mutations to be tested and some epigenetic testing, which actually are under research. Now, a lot of regenerative andrology is coming up, which has PRP therapy, stem cells, and the future would probably be the reprogramming which may take place. Now, I'll get you through in the end into an area which needs to be understood. So, in vitro generation of sperms is capable. It's possible for fertilization. How? So, in 2011, Takehiko Ogawa in Yokohama University, Japan, demonstrated that if he took a mouse which was azoospermic, took out the spermatogonial stem cells from the testes, they were able to culture and obtain spermatids and sperms, which resulted in healthy offspring. Now, this has been done in mice, but it has not been done in men. So, it may be possible in the future. Next, of course, I'll talk about CRISPR. Now, we all know about CRISPR, but CRISPR is an interesting thing. CRISPR is that you could replace an area of the genetic code by a new genetic code, just like, well, it's stemmed from the fact that when a virus infects a cell, it changes and places itself within an area in the DNA. So, similarly, you could change the DNA and put in a code. Now, why this becomes important is that supposing there is two people who have thalassemia, they want their own child, they have embryos. From those embryos, the thalassemic area could be removed and a new area could be substituted so that a baby born will be without thalassemia. Diabetes. Both have diabetes, and the area which is looking after diabetes could be changed. You could have some genetic diseases which could be modified. But in the future, though it will not come out probably because of ethical reasons, the best cricket team with every Sachin Tendulkar could be created by the codon of genetic Sachin Tendulkar. And a man would say, I don't have a wife like, I would say, Aishwarya Rai, but wants a wife like Aishwarya Rai, so probably the genetic designer baby, a daughter could be like Aishwarya Rai. I'm just saying it as a joke, but this is what a designer baby probably could be in the future. But probably it will not go into the world for ethical reasons. Now, I'll leave you with, in the end, with an area that now a sperm and an oocyte are needed for a baby. But if two men get married, one could give a sperm and a pluripotent stem cell from another man could be used to make an oocyte and both could have a baby. And similarly with a woman, and of course a surrogate will be needed. But in a woman, if there are two women together, they want a baby. One could give an oocyte and the other's pluripotent stem cell, you could make a sperm and both could have a baby of genetics of both. But the interesting thing is these two women will never be able to have a baby boy. So it's interesting. And I'll leave you with this. So it's very important for every man to be treated, and male infertility is treatable. Semen analysis is evolving. Advanced tools are available. Your role is crucial. Thank you very much. Now, you could scan this QR code, all of you. And once you've scanned it, you'll go and get all the PDFs, the top research presentations for DNA fragmentation, and also this particular presentation I have uploaded for you to actually carry this presentation with you. So you could just scan this, and when you scan it, you'll go on to an application and you'll be able to get all the PDFs and this presentation, which I think would be great. And I have also posted over there a presentation of how to grow on social media, because that is one of the most important things for all of us to do. So thank you very much. It has been a pleasure being here. And thank you, Dr. Manjusha. Thank you, all the people in the organizing team for inviting me here. Please take a screenshot of this. Please take a screenshot of this, which you could scan later. This is a small gift from my side to all of you. And thank you very much. Yeah,
Thank you so much, Dr. Sunil Jindal, for giving you such an enlightening and crisp talk. And I think you have covered almost every aspect of male infertility, which every gynecologist should know. But I would like to, on behalf of fellow gynecologists, I would like to take certain issues which you would like to clarify. There are certain questions, although you have covered almost most of the thing, most of the aspect. First of all, I would like to know, when should the gynecologist refer the male partner to the andrologist?
Now, there are two parts of it. The first thing is, whenever a gynecologist gets a patient of infertility, she needs to call the man and the woman both together, first thing. And in the first examination of the woman itself, and when you're taking the history, a semen analysis should be done in any laboratory which is doing it properly with a WHO standard first. Now, the second thing is, once the report comes to them, now there's a very big issue, or there is, I would say, it's not comfortable for any gynecologist to actually examine every man.
Yes.
So what happens is, either there should be somebody who could examine the man, or they should send the man to a person who would be able to examine this man properly. It could be any surgeon, it could be any physician, or anybody whom they know who could examine it. Now, once the report is there, the referral of this patient should take place whenever there is any loss of semen parameters. It could be oligospermia, asthenospermia, oligoasthenoteratospermia, or azoospermia, because this is the time when evaluation of this man should take place.
Yes. So you have covered so much. And what is, I just want to know, now the people are taking so much of this recreational drugs, they are taking smoking, alcohol, and this also. So how should the gynecologist explain that, what will it affect, how will it affect the semen parameters, even the impact of the scrotal heat, and how to explain it to the patients? And
Now
how does it affect the semen parameters?
I think, Dr. Saab, you've really hit the nail that this is some counseling which every gynecologist can do. Even if she can't
Yes.
examine, I think this is something which every gynecologist should do. So a
Yes.
few things are a no, 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 which is
Mm,
smoking, alcohol, recreational drugs, tobacco, chewing tobacco,
mm,
heat, laptop, saunas, cycling, tight undergarments.
mm,
That is an absolutely no. Now the next question is, what else can be done?
mm,
Exercise, walking. Food has to be the anti-aging food, which I think every human being should take, which means anything white and bakery products should never be taken.
mm,
मैदा मत लीजिए, चीनी मत लीजिए, मीठा मत लीजिए, sugar कम लीजिए, anything white.
mm,
Take everything which has choker in it, which means it could be wheat, ragi, quinoa, it could be makai.
mm.
What you need to actually take in fruits is those which are red and yellow, and vegetables which are green. Stay away from pollution. You should have very little food pollution. Uh, if there is any infection that needs to be treated, if there is any varicocele, it needs to be
Mm,
evaluated. So this is very important. I have so many videos on YouTube which millions of people have seen across the world, which
mm,
makes me very happy because this is a very small service which I could do. These videos also are very useful because they, in a nutshell, in 10 minutes, make the man understand that this is what he
mm.
doesn't have to do and has to do.
Yes. Okay. So antioxidant you have already explained, which can improve the semen parameters. I just wanted to know if is there any dietary supplement we should also recommend to the male. I think it has already been covered. Dietary supplement which may improve the semen parameters.
देखिए, बहुत अच्छा है। आप सवाल बहुत बढ़िया पूछ रही हैं क्योंकि
Thank you so much, sir.
ये बातें कोई करता नहीं और ये बातें करनी चाहिए। देखिए,
और मुझे लगता
अ,
है ये पार्ट बहुत इंपॉर्टेंट है कवर करना।
बहुत बहुत अगर 5% भी फर्टिलिटी आप लाइफस्टाइल डाइट से ठीक कर लें तो
हम्म।
5% बहुत बड़ा नंबर है
हाँ।
रस्सी के ऊपर फांदने के लिए। तो ये 5% कितना बड़ा देखिए आप।
और
देखिए
मुझे लगता
वॉल
है गायनेकोलॉजिस्ट का ही रोल आता है यहाँ पे सर
100%
इनिशियली।
100%। सो वॉलनट्स इज वेरी गुड। बादाम बहुत बढ़िया है। पंपकिन सीड में जिंक बहुत होता है, ओमेगा 3 फैटी एसिड्स होते हैं। सनफ्लावर सीड आप ले सकते हैं साथ में। मतलब ये सारी चीज़ें जो मेवा होती है, इस पूरी मेवा के साथ में बीजों का अगर आप एक छोटा सा बंच बना लें और एक मुट्ठी सुबह एक मुट्ठी शाम खा लें, दिस इज़ वेरी गुड। बिकॉज देखिए आपके स्पर्म प्रोडक्शन के लिए आपको कुछ माइक्रो न्यूट्रिएंट्स चाहिए, जैसे कि जिंक, और जिंक के साथ में
यस
आपको चाहिए सेलिनियम, ओमेगा 3 फैटी एसिड्स चाहिए,
यस
आपको एंटीऑक्सीडेंट्स चाहिए। लाइकोपीन लेना है, दिन में 4 टमाटर ले लीजिए, हल्का सा कुक करिए। आपको फॉर दैट मैटर ये जो होती हैं हरी ग्रीन वेजिटेबल्स फॉलिक
यस
एसिड के साथ में आपको एंटीऑक्सीडेंट्स देती हैं। तो ये सारी चीज़ें जो एंटी एजिंग होती हैं स्पर्म के लिए बहुत अच्छी होती हैं। मैं तो कहता हूँ विमेन को भी घर में खानी चाहिए क्योंकि पॉलिसिस्टिक ओवेरियन डिजीज में डीएनए फ्रेगमेंटेशन एग का खराब होता है। यही तो खाने खाने।
यस and also now the people are very fond of gym and there are so many male partners they are taking this anabolic steroid. I think it's affecting the semen parameters. This is also very important aspect, and how should we deal with it, and how should we cover it and explain it to them.
जब भी मेरी क्लिनिक में कोई आदमी आता है जिसकी मोटी मोटी मसल होती है, सलमान खान बनने की चाह रखता है, बाल कम हो चुके होते हैं, पेट अंदर होता है, छाती बाहर होती है, और बीवी साथ में आती है उसका हाथ पकड़ के और बिठाती है और कहती है ये देखो, और सीमन एनालिसिस में होता है जीरो स्पर्म, कम स्पर्म, तो उसे बताने में
Yes.
देर नहीं लगती दैट वन थिंग फॉर यू टू अंडरस्टैंड इज एनी एनाबॉलिक स्टेरॉइड और एनी टेस्टोस्टेरॉन
Yeah.
will get testosterone into your blood, but it will remove but what happens is FSH LH will get knocked off. बहुत सारा
Yes.
ऑलरेडी ब्लड में टेस्टोस्टेरॉन है, क्यों बनाए, एंड आपका इंट्राटेस्टिकुलर टेस्टोस्टेरॉन बंद हो जाता है, ओलिगोस्पर्मिया हो जाता है, इंपोर्टेंस हो जाती है। आप लोग सब पुराने लोग हैं, एक आपको याद है एक वो एक टूथपेस्ट होता था फॉरेंस, पता नहीं याद है कितनों को फॉरेंस याद है आपको, एक फॉरेंस टूथपेस्ट होता था उसका ना एक ऐड होता था कि एक बड़ा तगड़ा सा आदमी होता था कि शरीर इतना तगड़ा और दांत इतने कमजोर,
कमजोर
है ना, बिल्कुल वही हालत होती है, शरीर इतना तगड़ा और स्पर्म इतना कमजोर, ये हालत होती है उन लोगों की। तो ये बड़ी इंपॉर्टेंट चीज है समझने की।
Yes. Secondly, I just want to know this DFI fragmentation. Should the gynecologist refer? Is it a hope or is it a hype? When should we
नहीं
advise it?
देखिए देखिए मैं बहुत
हाँ,
सिंपल सी बात कहूँगा
हम्म,
डीएनए फ्रेगमेंटेशन एक बहुत अच्छा टेस्ट है
हम्म,
बट इसकी स्टोरी बहुत गलत है मैं आपको समझाता हूँ कैसे देखिए आपको डीएफआई टेस्ट करने के लिए बिल्कुल फ्रेश सीमन चाहिए आप उसे ट्रांसपोर्ट अगर करते हैं अपने शहर से दूसरे शहर की लैब
हम्म,
तो आपको फ्रीज करके देना पड़ेगा जो फ्रोजन सैंपल थॉ करके डीएफआई करेंगे
हम्म,
पर नॉर्मली होता क्या है कि जब आप किसी को कहते हैं इनका XYZ मल्टी चैनल पार्टनर इनकी एक
हम्म,
सीमन सैंपल ले लीजिए तो कहते हैं हाँ मैडम वो दिल्ली या बम्बई की लेबोरेटरी में जाके या एक्स जगह लेबोरेटरी में जाके टेस्ट हो जाएगा
हम्म,
तो वो टेस्टिंग नहीं हो सकती उसकी तो डीएफआई कराने के लिए जिस लैब में टेस्ट हो रहा है या तो वहां जाएं या आप
हम्म,
लिक्विड नाइट्रोजन में फ्रीज करके दें तो ये बड़ी इंपॉर्टेंट प्रॉब्लम है इसकी तो डीएफआई की टेस्टिंग अगर प्रॉपर की जाए दिस इज वेरी यूजफुल स्पेशली इन recurrent pregnancy losses
yeah,
IUI IVF failures अनएक्सप्लेन्ड इनफर्टिलिटी
हम्म.
आदमी को वेरिकोसील है पस सेल्स हैं इट्स वेरी इंपॉर्टेंट एंड इट्स अ वेरी यूजफुल टेस्ट
I think you have told very important tip. Normally, the gynecologists don't pay attention to it, whether where is it going for this testing. I think it affects the results also. Yeah. And secondly, this in cases of the azoospermia, this Y chromosome microdeletion is advised. So I just want to know, okay, what is the clinical significance, and the gynecologist tell the partner why to go for this test in cases of the azoospermia.
देखिए कोई भी आदमी हो जिसका 3 मिलियन से कम स्पर्म काउंट है या एजोस्पर्मिक है उसका वाई क्रोमोसोम माइक्रो डिलीशन होना अनिवार्य है
Hmm.
उसका रीजन ये है दैट इफ देर इज अ वाई क्रोमोसोम माइक्रो डिलीशन एंड इफ इट इज प्रेजेंट इन 3 areas there are 3 areas for it A B
Yes.
and C now if it is in A and B you will never find sperms so there is no point of taking up the patient for a micro TSA or a TSA. Now, if it is in C area, you may find sperms, but in case you use these sperms and a baby is born and the baby is a baby boy, he will also have microdeletion and he also will be azoospermic or severely
Yes.
oligospermic. So this needs to be understood and the patient needs to be counseled
Sure.
for it. Therefore, it becomes very important.
Yeah, this is very important. And you have shown very good videos of all the sperm retrieval techniques. I just wanted to know which factors predict the successful sperm retrieval in cases of non-obstructive azoospermia.
Madam, देखिए, I probably have extracted sperms in a man whose FSH was over 100. So the fact that people say it is 2 times don't do, 3 times don't do doesn't matter because that does not matter. But there are few factors which matter. Number one, size of the testes, level of FSH used to be considered earlier. It is not considered now. But in case you have a biopsy, number two, what is the cause of non-obstructive azoospermia? See, undescended testes which have been there in the abdomen and brought later, the chances of retrieving of sperms is less in them. In case there is a biopsy which you have received earlier and the biopsy shows hypospermatogenesis, you can get sperms up till 80% of these patients. Early maturation arrest, 30%, 20%. Late maturation arrest, about 50%. And in patients of Sertoli only, the chances are around 10 to 15% only. So you can make a judgment in case a biopsy has been done earlier that this could be there. But otherwise, it's very difficult to judge before whether sperms you would find or not.
Yeah. And we have to counsel the patient beforehand. We might
Absolutely.
get the sperms out. Yeah, it's very important.
It is the most important thing of the procedure.
Yes. Nowadays, I think the urologists, whenever they get the patient, they advise the patient to go for varicocele surgeries. I just wanted to know which varicocele warrant the surgical repair in the context of male infertility, and does it really improve the pregnancy rate?
I'll answer this question, a complicated question, very simply to you, because I do it every day. And we also
Yeah.
do IUI, we also do ICSI, we also do retrieve, we do
Yes.
everything. So
Yeah.
the ultimate aim is to help the patient. It is not to do a surgical procedure. So now, when will you do a varicocele surgery? So you will
Mm.
do a varicocele surgery if the
Mm.
varicocele is grade 3 or 4. You do not do it in a subclinical varicocele, number one. Number
Mm.
two, if the semen parameter is affected, you will
Mm.
never do it in a normal semen parameter.
Okay.
Number three, where you have evaluated the woman and you feel that the woman is close to normal. This is
Mhm.
another area to be thought about. The fourth important thing is the age of the woman. Now,
Yes.
supposing, I'll give you an example for it. There are a lot of patients which I get who are young, whose wives are young. They have a grade 3, grade 4 varicocele on either side. They are trained naturally. They don't have a baby. The man has oligospermia and
Mm.
also teratospermia. These are beautiful patients to operate microsurgically. Why microsurgically? Because you've got to save the testicular artery, and the testicular
Okay.
artery can only be seen microscopically. If you tie the testicular artery, in fact, it will do a lot of disservice because the blood supply to the testes will go down.
Mm.
So, you need to do a microscopic varicocelectomy. I've had patients who got naturally pregnant, patients for whom you thought I would do an IVF or ICSI.
Mm.
They got pregnant by IUI. And I've had patients in whom I thought it's a very poor sperm count and they come back
Mhm.
with a natural pregnancy. So,
Mm.
it's very important to judge what you need to do, number one. Now, supposing there's very severe oligoasthenospermia, and there is time which you have because the wife is young. By doing a varicocele surgery, you are improving the quality of the sperm, which you're going to
Mm.
use for ICSI.
Yes.
So it becomes useful. So
Mm.
ideally, you should do a varicocele surgery when you are clear about how it will be combined or complemented by ART.
Mm.
Unfortunately, what happens is the patient goes to any urologist, they say तुझे
Mhm.
varicocele है, चल तेरा ऑपरेशन करते हैं.
Oh, yeah, that is the thing. I've seen many patients. That's why I asked you this question.
While it
Mm.
should be understood in conjunction with the status of the woman who has to
Mm.
bear the child.
Exactly.
So that's the way it is. See.
Thank you so much, sir. I think you have clarified every answer so beautifully. I think everybody must have been benefited. I would like to thank you again. Thank you so much, sir.
Thank you very much, ma'am. And I'll just put up that scan again. You could take that presentation
Yes,
from there.
definitely. Sure,
I'll
sure.
just put up that scan.
Yeah.
Just put up that slide, please. You could just take a screenshot of this and scan it to take this presentation. So thank you very much, everybody. I think it has been a pleasure being here. And yeah.
Thank you so much, sir.
Pleasure.
Now I would like to invite Dr. Neha to proceed with the quiz conduction.
Thank you, ma'am. Thank you, sir, for a wonderful talk. And I would now request all the participants who've been waiting patiently to start with the quiz session. Now, for this year 2026-28, this is the first session that we are hosting. There'll be 20 questions that we will have, MCQs. We will get 20 seconds each to answer the questions. This quiz is being conducted on Kahoot. You must have downloaded Kahoot by now. If you have not downloaded Kahoot, please download the application. And in username, you put your phone number as your username, because that is how we can identify the winners. So it's in these 20 questions, it is your speed and of course, the right answer which gets you the points. And at the end of the session, we will see the top 5 scorers. The first top 3 scorers will put their numbers in the chat box, And the fourth and the fifth scorer also can put their numbers in the chat box. The two best scorers out of these 6 sessions will get an opportunity to be there in Fertivision, which is being held in December. So we'll give a few minutes for all the participants to download Kahoot and register their phone numbers as their usernames. We'll start in another 2 minutes, and your accuracy and your time will make all the difference. So you can scan the QR, which is being shown on the screen. Enter the PIN. Yeah, so we can see the participants in the chat box now. Please don't write your names. I can see few names coming up. Please write your mobile numbers as your username. So we already have 24 participants as of now. We'll wait for a few more seconds before we proceed. Once the quiz starts, the screen will be locked and we will not be able to add more people. Please write your mobile numbers and not your names. I'm repeating one more time. I can see few names coming up in the participant list. Whoever has put their names, can you please change it and put your mobile numbers here? Thirty-two participants.
I think Dr. Neha, we can start.
We can start.
Yeah.
We can start the quiz. Okay, so we go here with the first question. In infertile male, which single hormone is used as the first line test? We have seen excellent presentation by Dr. Sunil sir. And so the right answer is FSH. Okay, we got 24 people answer the question right. Great. So here goes the second question. According to WHO 2021 criteria, semen analysis, according to the reference values, what is the lower reference limit for sperm concentration? Here are the options. So according to WHO 2021 criteria, what is the lower reference limit for sperm concentration? Great. So we just learned in our presentation that WHO 2021 is revised to 16 million. Earlier it was 15 million per ml. So which is the most common identifiable cause of male infertility? Here are the options. Cryptorchidism, varicocele, hypogonadotropic hypogonadism, or obstructive azoospermia. What is the most common identifiable cause of male infertility? Excellent. So we learned that varicocele, we had a long discussion. And yes, varicocele is the most common cause identifiable. According to Aphrodite, group 1 is categorized by which hormonal profile? According to the Aphrodite classification, group 1 has what kind of hormone profile? In males, is it elevated FSH, normal testosterone, normal FSH, reduced testosterone, reduced gonadotropin, which is hypo, or normal FSH, normal testosterone with lower sperm parameters? Okay, that was very quick. So reduced hypo is group 1, according to Aphrodite. In unexplained infertility with normal sperm parameters, which test is most likely to identify a male factor? So we have unexplained infertility and normal parameters. Is it serum PSA measurement, scrotal ultrasonography, sperm DNA fragmentation testing, or penile Doppler ultrasonography? So yes, DFI as is the most common best test to identify male factor in unexplained infertility, idiopathic and infertility. Anosmia in an infertile male with hypogonadotropic hypogonadism is characteristic of which condition? This is fairly simple. The options are Klinefelter syndrome, Kalman syndrome, late onset hypogonadism, or AZFC microdeletion. So hypo with anosmia. Yes, so most of the people got it right. It is the Kalman syndrome, which is anosmia is a characteristic feature of Kalman. As per WHO 2021 guidelines, what is the lower reference limit for total progressive motility? Total progressive motility. 25%, 28%, 30%, or 32%? Fastest finger first. So 30% according to 2021 guidelines, which was earlier 32%. 17 people got it right. Great. In semen analysis, where the volume is 1.4 ml, concentration is 15 million per ml, the total motility is 42%, morphology 3% sperms are normal. According to WHO 2021, what is the diagnosis with these parameters? Is it asthenozoospermia, teratozoospermia, oligoasthenoteratozoospermia, or normozoospermia? Concentration of 15 million per ml, motility of 42%, morphology of 3%. So teratozoospermia because the morphology was less than 4%. Yes.
Dr. Neha, just wait. I just want to request Dr. Khushbu, please don't share answers in the chat box.
Okay.
Okay, you can, she's sharing all the answers in the chat. So please continue.
Right.
You don't have to share, Dr. Khushbu, and you don't have to share anywhere.
So you just click on the right answer. You don't have to share in the chat box.
Yeah.
So we'll go with the next question. Which Aphrodite group represents idiopathic male infertility with oligoasthenoteratozoospermia but normal hormone profile? Here are the options. Is it group 1, group 2, group 3, or group 4? According to Aphrodite criteria, idiopathic male infertility with OATS but with normal hormone parameters. So group 2, where the hormones are normal, but there is oligoasthenoteratozoospermia. Okay, so according to EAU 2025 guidelines, testosterone therapy is contraindicated in which scenario? Late onset hypogonadism with low libido, males wishing to achieve paternity, hypogonadism with mild erectile dysfunction, or secondary hypogonadism after pituitary surgery. So testosterone therapy is contraindicated in which scenario according to the European guidelines? So yes, patients who are wishing to achieve paternity, they should not be taking testosterone therapy. Which clinical finding would support a diagnosis of adult onset hypogonadism requiring evaluation? Is it fatigue alone, obesity alone, reduced libido, erectile dysfunction, and loss of body hair, or sleep disturbance alone? So adult onset hypogonadism requiring evaluation. Everybody got the question right. Dr. Parul, can you mute yourself, please?
Yes, yes.
Yeah.
Yes.
Yes.
Oh.
Okay, so we go on to the next question. The Aphrodite classification system was inspired by which female infertility stratification concept? So it came in the year 2024. And what was the stratification concept which was inspired, by which it got inspired? Can we have the options? Bologna criteria, Rotterdam criteria, Postone criteria, or Eshrey Atlas? Bologna criteria, Rotterdam criteria, Poseidon concept, or Eshrey Atlas? So most of the people did get it right. So it was According to WHO 2021, sperm vitality testing should be specifically performed when? Sperm vitality, when the sperm volume is less than 1.4 ml, sperm concentration is less than 16 million per ml, total sperm motility is less than 40%, or morphology is less than 4%. In which scenario should the vitality testing be performed? When the motility is less than 40%. The Aphrodite criteria are specifically not designed for which of the following patients? The Aphrodite criteria are specifically not designed for which patients? Male with idiopathic oligozoospermia, men with varicocele infection or obstruction, men with hypogonadotropic hypogonadism, or men with unexplained infertility. So any person with infection or varicocele is not included. Okay, which of the following is considered a characteristic skeletal manifestation of long-standing androgen deficiency? Long-standing androgen deficiency: osteoarthritis, scoliosis, osteoporosis with low trauma fractures, or Paget's disease. Long-standing androgen deficiency is associated with which skeletal manifestation? Osteoporosis with low trauma fractures. Which of the following metabolic conditions is commonly associated with androgen deficiency as per EAOU guidelines? Which metabolic condition is associated with androgen deficiency? Is it type 1 diabetes, hyperthyroidism, metabolic syndrome with insulin resistance, or Addison's disease? So, metabolic syndrome is associated with androgen deficiency. A male with infertility, azoospermia, anechoid features, gynecomastia with reduced testicular volume and raised FSH levels. What is the diagnosis? So a man presents with infertility with all these parameters. What could be the diagnosis? Is it Kalman syndrome, functional hypogonadotropic hypogonadism, Klinefelter syndrome, or congenital bilateral absence of vas? Everybody got it right except for one, but it is the Klinefelter syndrome. Which of the following agents most commonly causes infertility by suppressing the hypothalamic pituitary gonadal axis through negative feedback mechanism? SSRIs, selective serotonin reuptake inhibitors, calcium channel blockers, exogenous anabolic androgenic steroids, or the NSAIDs? So, which agent suppresses the HPO axis or the HPG axis? It is the anabolic steroids. Which lifestyle factor is cited by EAU guidelines as having a detrimental effect on both sperm quality and testosterone levels? Low caffeine intake, moderate physical activity, obesity and smoking, or vegetarian diet? So which lifestyle factor affects the sperm quality and the testosterone levels? Very, very simple question. Obesity and smoking. All the participants got the answers right. Which agent has a role in improving sperm quality and reducing oxidative stress in men with infertility? Which agent has a role in improving sperm quality? Is it NAC, N-acetylcysteine? Is it zinc, folic acid, or resveratrol? So, which agent improves the sperm quality by reducing the oxidative stress in men? No, resveratrol is the drug which reduces the oxidative stress. It's a very potent antioxidant. So this brings us to the end of our 20 questions. Thanks to all of you for active participation, and so our top scorer got 19 questions out of 20 right. That's excellent. And the second best got 18 right, and the third best got 17 right. Congratulations to all three of you. I would now ask Dr. Parul Garg, who is the convener for these quiz sessions, to take over. Thank you so much.
Okay. Thank you, Dr. Neha. So I will request all top scorer to share your phone number and email ID in the chat box. So I would like to thank Dr. Sunil sir for delivering an outstanding and enriching lecture on the male infertility, and also Dr. Divya for a cross talk and also and add an insightful uh, thing in the session. And a special appreciation to Dr. Neha for conducting a highly engaging and informative quiz, which made the learning experience more interactive. We sincerely thank all the participants for their enthusiastic involvement. So join for the next session that will be on 31st July. The topic will be ovarian stimulation and fertility preservation. Speaker will be Dr. Shweta Mittal, and that will be followed by the quiz. So looking forward to another exciting academic session. Thank you. And I would also like to thank our organizing team, especially our mentor, Dr. Manjusha, and co-convener for organizing such a interactive quiz and this first debut quiz session. Thank you. So winners have shared their, let me check.
Yes, so winners have shared their names.
So please take, I think, one photo. Yeah, just a second. This is, suppose, Dr. Darshan is rank 3.
Dr. Polki,
Yes.
Manisha is rank 2.
And first is rank, acha, this is Shreya. First rank is Shreya. Third is Dr. Darshan, and second is Dr. Polki. Fine. Thank you. So we can. नेहा ले लिया आपने भी एक फोटो ले लो इनकी.
Okay.
Polki, Dr. Darshan.
Rank 1, where did they post? I can't see that.
Rank 1 is Shreya. I have all the details of rank 1. Rank 3 का I think वो चाहिए.
Yeah,
Mail
Dr.
ID.
Darshan's mail ID is there. I've taken the picture.
Okay, and rank 3? Rank 3 is Darshan.
Dr.
Rank
Darshan.
2 is Polki.
And 2 is Manisha
Oh,
Polki.
okay, fine. Thank you.
Thank you.